I wanted to talk about Perio today because I feel like it's such an often overlooked issue. And if there's anything that can help the dental office, the hygienist, the dentist, bring up that conversation about Perio, I think it's a huge factor and it's a huge win for the dental office.
Yeah, I couldn't agree more. So I guess as we kick this thing off, let's, if you will, expose this 800-pound gorilla that is in the room and has been in the room forever. We do know that, with data, about 60% or more of periodontitis actually goes undiagnosed. And you can see these numbers on the slides. It's so prevalent. It's a real problem for society. And I think that the way I view this is it's oftentimes a hidden problem since it's asymptomatic, right? And patients don't really know the severity of their condition. They oftentimes dismiss it. And I think, unfortunately, we in the profession do some similar stuff. So I think it's a problem that's definitely worth tackling. There certainly is a lot of value in getting this right for society. And can technology help us do that, right? When we couple these statistics with this statistic I'm going to show here, which is around case acceptance, right? And patients turning down more dentistry than we would want them to turn down. That really, to me, Eric, highlights the depth and the breadth of this problem. It isn't something small that we can make incremental gains on. It's something that affects so much of society that I believe that we need to dedicate a lot of energy to this. How do you feel about, kind of that concept?
Yeah, well, this presentation you titled The Silent Assassin, and it's because why? Because it doesn't hurt usually. Patients come in with periodontal issues and it doesn't hurt. And I hear this a lot from new patients. They'll say, no one ever told me that, or no one ever probed around my gums like you have. And I don't know why that is, why we're so comfortable telling patients about caries or needing a crown, but why dental officers are so hesitant to talk about perio because it's such a problem. And if patients, first of all, if they're not told about it, second of all, if they don't understand what you're telling them, if they're not properly educated, they're not going to move forward. They're not going to just come in and say, "Hey, I want to get some scale and root planning done." They have to be properly informed and educated.
Yeah, and it's interesting you mentioned about probing. So many practices struggle with the being consistent with probing and taking periodontal measurements and taking documentation around that. How did AI specifically help you, in your practice setting, close some of those gaps? Can you talk to that a little bit?
Yeah, we always had, part of our hygiene protocol and workflows and part of our systems to probe. But, when you're probing and you're mentioning these numbers to patients, sometimes it just doesn't click on what you're trying to tell them.
Mhm.
So, I really try to talk to patients in lay terms, so they understand what we're talking about. Instead of saying the word probe, I'll say, we're using this. It's kind of like a ruler, and we're measuring how deep the ruler goes in your gums, and the higher the number, the more bone loss you have, and more inflammation you have. I try to speak to them in lay terms so that they understand. But when you open up the AI and you show patients the measurements, it just opens up that conversation that a lot of dentists and hygienists just don't want to have. We don't want to be the bearer of bad news, and try to explain to a patient that they have a problem and it doesn't hurt. They don't feel it. They didn't know about it. So that's where I really feel like where AI really came in to help me in my practice.
Yeah, and I'm thinking about sort of the main features and value prop that brings to the dental chair. What are the main features that you actually use? We talking about bone level measurements, the overlay itself with the colors and the quantification, or maybe longitudinal comparisons between a T1 and a T2 and a T3, for a patient over time.
Yeah, the measurements and the colors. I mean, it is, I tell patients it's like a traffic light. And there you can see it, there's, red, yellow, green, like a traffic light. And, red is stop and it's bad. When you show a patient these x-rays and you show them the measurements, they're going to understand more of what you're trying to tell them and the problem that they're having. And the chances are higher that they're going to move forward with treatment because they understand it. And the colors and the measurements, and I know with the PAs, it'll actually show percentages of bone loss. That transcends language, it transcends case presentation, it transcends if you're shy, if you're tired. The AI doesn't get tired. The AI speaks every language. Patients will understand these visuals more than trying to explain. Explaining dentistry is hard. Trying to explain to someone about periodontal disease, that is hard and exhausting. And if it's at the end of the day and you've seen 20 patients and you're tired, you're not going to explain it as well as if you're fresh at 8 a.m. So the AI just helps.
Yeah, and you know what I've heard recently from a number of folks out there is that they are in sort of this mode when they're using AI and the visuals where they're pausing their conversation to allow the patient to interact visually with the imaging and then have the patient come to them. And I'm hearing reports of things like the patient's pointing out a red spot or a marking or a number on an X-ray and saying, do I have a problem there or I have a problem there, don't I? Have you experienced that type of thing with your patients?
Yeah, they'll say, "What's that red spot?" It's boom. It turns the conversation into focusing on a problem that they probably have. Sometimes, I tell them there's maybe this is radiographic burnout, which I'll explain to them what that is, or there's maybe a radiolucent liner under their filling that's showing up red. And again, I talk to them like I'm talking to my 10-year-old son. I talk in lay terms. I don't talk dental jargon because they're not going to understand. But I always sit them up. I make sure they take we give every patient, sunglasses, eye protection. I make
Mhm.
sure they take their glasses off. I sit them up so they can see, and I move my large body out of the way so they can see the screen. And we just go over their x-rays together and we start pointing out red areas. I personally like to turn the AI on and off. I'll hit the space bar and I'll show them this is what a traditional digital x-ray looks like. And then I'll turn the AI back on. I'll say, now here are the AI annotations. And most patients are impressed. They think it's great technology. And I always say, this is a company out of MIT because I'm close to Boston, and that the local patients here love that too.
Mm.
But they'll just point out areas. I mean, the red areas are an obvious issue that's going on, and we'll just review the X-rays together and point out problems. So it really helps in that patient education process.
Sure. I hear a lot about workflows, right? There's this conversation around changing of workflows and is that harder or easier and where are we going to land with that? Talk to me a little bit about who reviews the AI first in your practice, because obviously there's a role for the doctor, there's a role for the hygienist, there's a role for the treatment coordinator, the front office, specifically to the clinical piece who is actually looking at the AI annotations first with the patient in your setting?
That's an amazing question because I'm very big on workflows and SOPs or standard operating procedures and having protocols in place. And it's just made my life so much easier. So I have a whole protocol for this workflow, and I have my hygienists do all the data gathering first before they message me. We have an intra-office communication system, so they'll
Mhm.
ping me when they're ready for their exam. And I have 5 hygienists to see. So sometimes I'm running around. And the last thing I want to do is get in there too early, and I don't want to get in there too late where people run behind. So the hygienist will do all the data gathering first before they start the cleaning, the
Mhm.
mechanical cleaning. They'll take the x-rays, they'll do the charting, they'll take any photos. If it's a new patient, we'll do diagnostic scans. They'll take all of that and then they'll tell me they're ready for an exam. And at that point, I know I can pop in at any time. So the hygienist has already reviewed the x-rays with the patient. They've jotted down any areas of concern that they want me to look at. And then they'll start their cleaning. And that's when usually I pop in because I don't want anyone to run behind. I don't want to pop in too late or too early where they haven't been properly charted. So when I come in, we just review them again. So it's a second time the patient is seeing the AI and the X-rays. So it just reinforces any potential issues that were brought up with the hygienist. It's a co-diagnosis with the hygienist. They're
Yeah.
bringing up an issue with the patient, and I'm agreeing or disagreeing. Usually, I'm agreeing because they've been with the patient for the past 30 or 40 minutes. I'm just popping in for 3 minutes. And, they were with that patient and, cleaning their teeth and seeing what was going on and probing. And then I pop in and we create a treatment plan from there.
And so you're validating what the hygienist findings are, and I guess in another manner of speaking, validating what the AI outputs are, putting that human stamp on the information that the technology is actually delivering at the chair, right? And I think that's important from my perspective, that this is not really about the technology overriding something that we're doing. In fact, I think it's just the opposite of that. I think that the technology actually is augmenting what we already do really well, but maybe helping us do it more efficiently, and then delivering some sense of, if you will, co-validation, because it can work the other way too, right? The computer can validate your assessment of the patient as well, to ultimately drive the understanding that the patient oftentimes, at least historically, hasn't had. So, you think about training and calibration, because you mentioned systems in the practice. What kind of things did you guys have to do in your office when you first put this in, to be able to have everybody, let's use the term, trust the AI output as an example? Because it is new, right? This is a new thing for all of us in dentistry.
I think that's the key word there is trusting it. And I still, like I mentioned earlier, I turn it off, I turn it on. We're the clinicians. We're the ones making the diagnosis. If there's caries, I'm the one drilling into that tooth. I want to make sure that the AI is right. And I'll turn it off, I'll turn it on, and I tell the patient, this is like a great second opinion. I totally agree with the AI. It's showing that you have bone loss, and the hygienist has already mentioned about the bone loss, about the need of scaling and root planning. So I'm like the second opinion, and then the AI is like the third opinion. And we'll just tell the patient, yeah, we totally agree with what it's saying. It's great, it's a great backup. Now, when I first started out as a young dentist, looking at an FMX in front of, especially in front of a new patient, was one of the most intimidating things that I experienced. And I wish I had this 20 years ago when I first started out, because it's like a second opinion. It's like other, hundreds or thousands of dentists have looked at these x-rays and are giving you their opinion. But there is a trust factor. And when you're starting out, you gotta just constantly get it into your workflow. Remind everyone to use it. I'll bring it up at the morning huddle, and I'll say, everyone, make sure you use your AI. It's just that reminder, and eventually it just becomes part of your day. It becomes part of your workflow. It's just like, doing anything else. You get used to it. So it's
And,
just a
and
matter of just keep going over it, reviewing it, because as dentists, you can't be the only one that's excited about this. You have to
right.
get the whole team on board, and it some doesn't happen overnight. You got to just keep reminding people and going over and over and over that this is there to help us, and it's a great technology, and it's super impressive to patients.
Eric, how long do you think that process of team calibration, and then sort of, if you will, muscle memory took for your team?
Yeah, we have the morning huddle, so I would mention it. I use the morning huddle like a little team meeting every morning. We review uh, who's overdue for treatment, where to put emergencies, really important things. But I'll review topics for the day, and I always, in the beginning, remind people of a new technology or new treatment. And there's still times where, I'll walk into the hygiene room and it's not up, and we'll have to remind, the staff to turn it on. So it still happens, but it probably took, a month or two to really get people into the swing of using it. But it's like you just plant seeds, every day I just kept planting that seed that we got to keep using it.
Sure, sure. Let's talk about case acceptance for just a second. In your practice, have you noticed any changes in SRP or maintenance acceptance around the AI visuals and for the patient being able to understand what the importance is of a disease that oftentimes is, again, the silent assassin. Unheard. It doesn't hurt. Yeah, when I floss my gums, they bleed a little bit, doc, but I don't have a problem, kind of thing. Have you noticed changes in the acceptance levels?
Yeah, and the AI is it's just another tool in your tool belt that you can use
Mhm.
to help educate the patient. Because again, if it's not hurting, I mean, the easiest thing to treatment plan is when a patient walks in with a broken tooth or it hurts.
Yeah,
It's easy to treatment plan and get case acceptance. But especially a new patient, if they're coming in and nothing hurts and they're not having bleeding or they're not complaining of any symptoms, then the AI is another tool. But you've got to, really educate the patient. We take good photos. We have videos that we show patients. It's just all part of the education process. And, usually we get patients to move forward. If they don't, then we keep bringing it up. We just keep at them. There's bleeding here. Your gums are not healthy. You're getting bone loss. We don't want to lose these teeth, and just keep at it. And eventually they do come around. Maybe not, right after the first appointment, but we don't take the scale and root planning off the treatment plan and archive it. We always keep it on there and just keep bringing it up. And usually also after we have pretty good success with keeping the patients on a 3-month recall after.
yeah. And that brings up the concept that I mentioned earlier before, which I think is one of the most important ones around this particular type of technology, is the ability to look at it through time. You and I both know, and I'm sure the audience knows, that a snapshot of a dental condition oftentimes doesn't tell the full story. In fact, it never does tell the full story. It's oftentimes what is happening over time. And I think in the realm of perio, especially, because the patient can feel the same on day one and year 50, right? They can feel the same exact way in their mouth, and yet their mouth can be completely different over time, to the point of now my teeth are at jeopardy for being lost completely, and I never even knew about that. So, talk to me a little bit about that and how that concept is translating to, maybe you use the term, I don't want to use the term deferred, but a later case acceptance than on day one, because it's still important, isn't it?
Yeah, and sometimes it happens. New patients, maybe we educated them, we told them about the periodontal problems, and they didn't move forward with scaling and root planning. But we'll hit them up the next time, and just keep reinforcing it. We also have written and documented protocols for patients with periodontal issues. As a team with the hygienist, we got together with our periodontist, and if you don't have a periodontist, then I recommend getting together with your local periodontist that you refer to and come up with a game plan, come up with a recipe, a workflow. What if a patient has uh, really deep pockets? What if they didn't respond after scaling and root planning? What do you do? When do you use a Reston? When do you refer to the periodontist? If there's recession, when do you recommend gum grafts? We've come up with all of these potential issues and protocols. So we have a kind of like a workflow that we use. But yeah, it does happen where patients they didn't move forward,
Hmm.
whether it was because of money or because
Hmm.
they didn't totally understand what was going on, or they just felt like they could just wait. It wasn't a problem that was an urgent problem. Maybe they had other restorative issues they had to take care of, but we'll just keep at them at recalls, and ultimately we'll get them on the schedule to get them, headed in the right direction and taken care of.
Yeah, absolutely. I'm thinking about clinically, right? One of the challenges with perio is determining whether a problem is soft tissue or is hard tissue, and that's really really important because the therapies are different, and this is a sort of a common appearance, right? Maybe this is a teen or a young adult or something like that, and you can look at these real beefy red gums and it's sort of they're flaming at you, right? They're screaming, and I know when I practiced, I heard oftentimes, you're looking at this visually, and this is a perio patient, a quote unquote perio patient. But the ability to look at the bone level measurements, as you can see on the X-ray, really really deciphers that for you. It gives you the ability to know that rather than just kind of guessing at it. you know whether there's bone loss, you know how much there is, you can quantify it. And then really that comes into making a much more specific diagnosis, doesn't it?
Oh yeah, absolutely. And I always talk to the hygienists, and we always talk about using your best clinical judgment, and what's best for the patient and their situation. And if you don't have the proper X-rays or the proper PAs, you're not going to get all the information. So this would be a case that looked like they had major periodontal problems, but when you look at the X-rays and the AI shows not much bone loss, then maybe you create a different treatment plan. So yeah, I mean, you've got to have the necessary X-rays, and get your team together, get them all on board, get them all on the same page.
Yeah, we need to speak the same language, right? Certainly
Hmm.
the teams do. Kind of another clinical example, I guess, for the audience here, again, blunted papillas, you can imagine this is bleeding every time you look at it. And it can really, really look like a periodontitis situation visually. But as you can see, no evidence of any bone loss. I did a um, literature review last year on some NIH data and talking about what the actual levels of CEJ to bone crest measurements should be in the normal situation. And I'd practiced a long time and kind of forgot that it went out the window for me, right? But in looking at the literature, that's like zero point 0.4 to 1.9 millimeters from CEJ to crest of bone when we look at it on a bite wing in a healthy periodontal situation, right? So the ability to look at a visual here, maybe on the left side, and then tie that to some information on an X-ray, and maybe you think about the concept of staging and grading as one example. This just allows us, in my view, to be able to be much more precise than we've ever been in the past. In the old days, it was, well, I think you have some bone loss here. Maybe it's generalized moderate bone loss. Now we could point out the surface on the tooth, measure it specifically to the tenth of a millimeter, and really have a definitive kind of idea of what's going on with the patient, right?
Yeah, and I actually started out in my career with regular paper film X-rays, and we
Mhm.
had dip tanks for when I was doing implants to get a quick X-ray. And then we went to that next step where we added digital X-rays, and that was like a major game changer. Now, when you add AI, it's like the next level up where it helps you as the provider. It makes your life easier. It makes you better, and it makes educating patients easier. So, to me, it's like that you're just going to that next level.
Yeah, so before we jump into the Q&A, because we are moving toward the bottom of the hour, for folks who are in the audience, Eric, that are listening and might think about jumping into the AI pool, as it were, maybe starting on Monday morning. So what is the first, let's say, month or 30 days playbook look like for that persona who might be thinking about jumping in and adding this to their practice?
Yeah, I would say the most important thing is if you have the AIs to use it, make sure everyone is using it, and it's just part of your workflow. You take the X-rays, you sit the patient up, and you review the X-rays with them. And there's a big, juicy class two area of decay there. It is so much easier to point to that big red area and tell the patient this is bad. This is a big cavity. We need to get you back in and fix this. And then you can point to the yellow areas. That's like caution. I
Hmm.
would probably do that, that MOD because I'm already in there doing number three MO. So I'd probably do number four MOD, and I'd have that conversation with the patient. But then it's picking up all the tartar, all the calculus,
Hmm.
and it's picking up bone loss. So there's a lot going on with this one bite wing, and it just jumps right out at you. And to me, when like mentioned, when I first started out, I'd be looking at this X-ray for like, 5 minutes trying to, figure everything out and explain it to the patient. Now it's so quick and easy to show a patient with these color differences and these measurements.
Yep, got it. I love that for sure. As we're coming into the bottom here, let's bring it home with a couple of questions. I do see a couple in the chat. First one is, how do you treatment plan when you see red on Overjet, but the probing you get 3 millimeters and recession at 3 millimeters? with total clinical attachment loss of 6. I think this is a really, really important question that goes back to our roots. And Eric, you and I both know that, and we talked about this, that differentiating clinical attachment loss from soft tissue measurements is really important, right? You can have a reduced periodontium and the patient can be healthy. In other words, stable. There's no inflammation there. There's no bleeding there. So I think from the RDH team perspective, the hygiene perspective, understanding that probing depths don't always match bone level measurements, nor should they, right, all the time. And understanding that calibration piece is critically important because knowing that for the entire team allows us to communicate it properly from team member to team member and then from team member to the patient, which is the most important part of it all, right?
There's so many factors. The patient's, what's their medical history, medications. If there's no, bleeding or inflammation, with probing, it totally changes the treatment plan. Are they, if they haven't seen a dentist in 5 years, are they, being treated regularly? Is so many
Mhm.
factors. It's so multifactorial.
Yeah, yeah. Next question is around accuracy. How accurate is the AI? Is it able to detect if the X-ray is taken in a wrong angulation? That's really an interesting question, isn't it? And I think it's a really good one. It goes to sort of the use of the tool. It's very accurate. Now, all of the models, and there are a lot of different models that are running on these images, things like cavities, calculus detection. We're talking about perio bone level measurements, but they're all a little bit different. They all have their unique characteristics in terms of how sensitive or how much specificity they have. You can dig into that at fda.gov for sure. All of that is publicly accessible, is very easily readily accessible for you at the FDA. And then the second question around if the X-ray is taken in the wrong angulation, can the AI detect it? The answer is yes, it definitely can detect it. And just to give you a little sneak peek of what may be coming down the pike is utilization of AI to grade X-ray exposure quality will be coming in the future. So really cool things are coming that are being facilitated with artificial intelligence and automation. And I think for the audience, take advantage of understanding the technology and learning about it because it's something that will certainly be affecting all of us in our practice careers.
I just wanted to follow up with just reminding everyone that you're the clinician, you're the one making the diagnosis, you're the one making the treatment plan. I turn the AI off, I turn it on. I make sure that it's, if I'm treatment planning a cavity or caries, I'm making sure that it's accurate. It usually is, but occasionally there'll be some radiographic burnout that it picks up, and I'll turn the AI off and I'll tell the patient this is just the curvature of the tooth on the X-ray. We don't have to worry about it. We'll just follow it. So always use your clinical judgment.
Yeah, 100%. That's really a great call out. Probably the biggest bullet point for today, right? Well, listen, Eric, this has been fantastic. It's always great talking shop with you. I always enjoy doing this, and thank you very, very much for donating this time to the cause today. For you folks in the audience, should you have further interest in this topic or any of them around artificial intelligence, you can reach out to us here at Overjet. I am connected with Dr. Block real closely, and we both, I'll speak for you, Blocky. Are happy to talk to anybody that wants to ask questions about this stuff at any time. So thank you all for attending and hope you have a wonderful rest of your day wherever you're practicing dentistry from.